Welcome everyone to the March Masterclass. This is about the Sexual Abuse Referral Centre. We've got Emily here who's going to talk to us today about that. So I'd just like to welcome Emily. Just a couple of housekeeping rules before we start. First off, just to be aware of your environment, of your noise in the background. If you do have your microphone on mute, please mute yourself. We will also be recording this session. We won't be putting anybody's face on it. Will just be the slides from the presentation, so don't worry about that. So that'll just sort of keep some confidentiality. And please add any questions to the chat if you want. And Emily, I don't know if you want to have people come in during your talk at all, but please let us know any questions that you have. Okay, so in that case, I would like to just introduce Emily from Western North Yorkshire Paediatric Lead from Mountain Healthcare Limited. So welcome, Emily, and I'll pass things over to you.
Hi, thank you. Sorry, I'll just bring up my presentation that I've kind of prepared. Just bear with me. But it's nice to meet you all virtually, and thank you for having me. As Hayden said, I'm the paediatric service lead for both West and North Yorkshire. But obviously we're going to talk specifically about the North Yorkshire Paediatric SARC, the Sexual Assault Referral Centre today. I would ask if you've got any questions, please feel free to raise your hand and we can ask them as the presentation continues. I'm more than happy to do that. But I just want to give thanks to one of our doctors, Dr. Bethan Little, who kind of helped with putting these slides together. Yorkshire SARC, the Sexual Assault Referral Centre. I hope you can all see my presentation and the slides that are on the screen at the moment. If you do have any questions during the presentation, please feel free to raise your hand and we'll answer them as we go along. But just to give a bit of an overview about the SARC and the SARC provider. So North Yorkshire SARC is provided by Mountain Healthcare Limited. We are the largest SARC provider in the UK. In terms of the paediatric service, we've provided that paediatric service in North Yorkshire since 2020. We support patients aged between 0 to 15 years old. That can be up to the age of 18 if there's complex needs or additional vulnerabilities there, but that's very much on a case-by-case basis, but usually it is up 0 to 15. We offer both acute and non-recent appointments, so pending when the incident's happened. It can do. Sorry, there's just a bit of background noise. I do apologise. But yeah, we do offer both acute and non-recent appointments, and I'll talk a bit more a few slides later on as to how we triage those and what makes it acute and what makes it non-recent. We're also very fortunate to offer a follow-up STI service. So for children, young people who've disclosed an acute assault and they've been seen, pretty urgently within the SARC. We do baseline STI screening, but the incubation time for those infections can differ. So when we take those baseline screening, it may not necessarily show the infection. So we're very fortunate to run an in-house service where we can go out and repeat those tests to confirm that there's no infection there. Just as a comparison in terms of the adult service, we've provided this service since 2016, and that does support patients aged 13 years plus. There's a bit of overlap. So when I say support patients aged 13 years, that's for patients who've disclosed acute assault. So where they'll be seen and who they'll be seen by will be different. But again, I'll explain that in a little bit more detail later on. And in the adult service, it's only acute appointments, so something that's happened within a certain time frame, unlike the paediatric service where we can also offer non-recent appointments as well.
You've got on mute again, Emily.
Why does it? Sorry, I do apologise. I don't know why it keeps doing that. But yeah, sorry, an overview of our service, in particular the North Yorkshire service. We see children and young people following an allegation or disclosure of sexual abuse or assault. We do see children, young people who have not made a disclosure. However, there's that professional concern of sexual abuse there. That could be for a number of reasons. They've been residing with a registered sex offender. They could be symptomatic for, a sexually transmitted infection. They could have anal genital warts, for example. There could be a number of reasons why we see a patient, even though there's not been any disclosure there. I had no idea what is going on. Sorry, everybody. There we go. So one of the most important messages that I could say is that we don't just do forensics. A lot of professionals and members of the public, when they think of the SARC and the term of rape kits, as some people call it, it's all about the forensics and getting that forensic evidence for the police for in terms of an investigation. However, we like to think that we are so much more than that. It's about that holistic assessment of a child or young person, following a disclosure of assault, going through such a horrific incident. It's making sure that their needs are supported moving forward. So this kind of links to our non-recent appointments. To even if they're out of the forensic window, we've run out of time to take any forensic evidence, we will still see them for that holistic assessment and make sure that they're okay and the appropriate referrals are made afterwards. But in terms of what we offer, as I've said, we can take forensic sampling if we're within the certain timeframes. I'll go into detail about specific timeframes and when we can take those samples. It's about that holistic injury check, the documentation of any injuries they may have, baseline STI screening, our in-house STI nurse follow-up service. We also have on-site HIV PEP medication. So if an incident has happened it is quite a short time frame, so something that's happened within 72 hours, we do have medication on site. The doctor will do an assessment, what is the risk that this child or young person has been exposed to HIV. If that is deemed high risk, we would prescribe them a month's regime of HIV PEP medication. It's not 100% effective. However, it's the chances of then contracting HIV after taking a full course of this medication is significantly reduced. So that is something that we offer on site as well. Again, emergency contraception, if something's happened very acutely, within 72 hours, we can offer the emergency contraception on site. And then a big part of what we do is obviously referral to support services to make sure that they're supported moving forward. So obviously, given we're a paediatric service and, why a child or young person will be coming through to us, we have that huge responsibility and that, the duty to safeguard all of our patients. We routine information share with GPs. Is a really beneficial service called the CHISVA service, so that stands for the Children's Independent Sexual Violence Advisor, and they're very much, the work is kind of a bracket of IDAS and victim support through the police, but they're also very much independent. So if a case was to go through the criminal justice system, if it was to go to court, the ISVA is a very key person that would liaise between the police and the family to keep them updated in terms of the investigation. If there was needed to be given evidence in court, for example, the ISVA would work with that patient to prepare them for that, what to expect. They do court visits with them, etc. They're just a really key person to be referred to. And if they feel like the patient needs more specialised treatment, specialised counselling, they can also make onward referrals to other services as well. Obviously the CAM service, a lot of our patients do have, additional vulnerabilities, for example, self-harm and mental health concerns. So it's really important that we have those relationships with CAMs and refer and information share with them when necessary. CSE support, so child sexual exploitation. We routinely do a risk assessment for CSE on every patient over the age of 12. That is kind of the age where we deem children, young people to be more at risk just due to factors in their life, social media use, becoming more independent when they go to high school, etc. But not to say, if we have a younger child where the information in the referral is, concerning for CSE. That's not to say we won't do a risk assessment. I think the youngest child we've done it on is around 8 years old, but that in terms of anybody over the age of 12, it is something we routinely do. And then that risk assessment, when completed, will be shared with local CSE teams as well as the child's allocated social worker as well. Information sharing with school nurses and health visitors, and we can also information share with other agencies at the patient's request. You know, a lot of our patients want us to inform, you know, safeguarding leads at school so they can be supported in school, so they're aware of what's happened. Obviously, we always get patients' consent, you know, but it's really important to kind of information share with these key agencies, just so, you know, if the patient was to approach them, you know, approach a teacher at school or a senior member of staff, they wouldn't have to go through what's happened and relive that trauma. It'd be for us to information share so they have that information to hand and they don't have to ask questions around what's happened. So this is kind of just an overview as to what the acute 0 to 12 service is, and then the non-recent, which would be 0 to 15. So I'll start with the acute 0 to 12 service. So this is anything that, you know, any disclosure, any incident that has happened within the last 14 days. So if that is the case, you know, we're within that time frame, they'll be seen by a doctor and a crisis support worker. They won't be seen in North Yorkshire as it stands. The service is commissioned to be provided by the Hazelhurst Centre, which is currently in Leeds, in West Yorkshire. But they'll come through to us. You know, if it's a forensic, there'll be that extra urgency for them to be seen to make sure we get those forensic samples. We're not a 24/7 service, unlike the adult service, obviously because it's not deemed in the best interest of a child to bring them through at 2 o'clock in the morning. So we have specific clinic times, so like Monday to Saturday 10 till 6, and then Sundays 11 till 4. Obviously we have the opportunity to take those forensic samples if we're within the specific time frame. We can assess for emergency contraception, HIV, PEP, like I've already spoken about, that holistic injury check and assessment. We also record the examination, and when I say record, that is solely of the intimate area. You know, it's not, the child or young person is not identifiable. The face is not in any of the videoing. You know, there's no sound, and they're all shared or saved, via a unique number. The child's name is never put on any of those images. The main reason why we do that is because if there was to be an injury there, we can then share the images with they're never shared between professionals in terms of, you know, social workers or police officers. These images are only shared between medical professionals. So if there's an injury there, we can share it with another doctor for a second opinion, or we can go to a senior doctor, you know, for their opinion as well. And that's solely because we won't have to then bring the patient in for a second examination, because nobody wants the child to be examined again. So that is the main reason as to why we take those recordings. And then obviously any outward referrals, that'll be appropriate. And then the doctor who sees the patient will complete a detailed medical report, you know, explaining the circumstances and any outcomes from the SARC medical. In comparison, your non-recent, so that's anybody aged between 0 to 15, and they're triaged as 14 days have surpassed since the incident has happened. Again, they'll be seen by a doctor and a crisis worker. There is 2 options as to where they'll be seen. Obviously, patients' best interests will be considered in this case. But firstly, they'll be seen on a Friday at the Bridge House SARC in York. Or, you know, if there's the patient wants to be seen sooner, and they're not really bothered in travelling, you know, an extra distance, they can be seen within our clinic in Leeds. That's mainly because, like I say, they can be seen sooner and have that medical as soon as possible. And then in terms of, you know, holistic injury check, assessment, recording of the examination, referrals, medical report, etc., that is all the same as to what it would be if it was an acute. The main difference would be obviously forensic samples. In a non-recent examination, we wouldn't be taking those forensic samples because we'd be out of time frame. So just to give you a bit of an overview as as the premises, I'm talking about these clinics. So as you can see, Bridge House in York is very much a house. It's in a residential street in York, in North Yorkshire, and that houses both the acute 13+ service, which is a 24/7 service because it falls within the adults, and then the non-recent as well, which is on a Friday. Anything else, so if they're acute and they are aged 0 to 12, they would be seen at the Hazelhurst Centre or Sunningdale House in Leeds. So just to give a bit of a comparison. I know I've touched on the acute clinic. This is specific for young people aged over 13 years old. It is not very different, but there is some differences into the service that they have. But there is their option to attend 24/7. The clinic hours. It's never closed essentially, but we do consider whether that is in the best interest of them to attend overnight. They are seen by a forensic nurse examiner, not a doctor, but they also have a crisis worker with them. No medical report will be produced. However, statements from the nurse can be requested by police if required, and patients also have the option to self-refer. So obviously, unlike the acute 0 to 12 years, we don't have the option to self-refer given the age of the patient and what has happened. However, if you do have a 13-year-old and they're a bit unsure as to whether they want the police involvement, they can self-refer to the SARC and get those forensic swabs if they want to do so. We obviously have to have that very difficult conversation with them that yes, you're unsure as to whether you want police involvement, but obviously it's our duty of care to inform social services, and a lot of the time they're very open to that because they want that support from people. And just to give a bit of context, the North Yorkshire SARC is due to move premises. We've been very fortunate in getting funding from the Police and Crime Commissioner to move to another premises later on this year, but further details will be released in due course about that. Just to give a bit an overview as to the age of the patients that we're seeing. So as you can see, we see more 0 to 12 years old, so 71%, unlike the 13 to 15-year-olds, which is 29%. So there is a significant difference there. I've spoken about the forensic timeframes. So if a child or young person, discloses something has happened to them, we firstly have to look whether, it's been within the last 2 weeks. So if it has done, we will then look at more specific timeframes as to whether or not there'd be any forensic swabs to take. The forensic swabbing does differ as to what has happened. So just as you can see on the screen, if vaginal penetrations happened, we have up to 7 days to take those swabs. Anal penetration, that's 3 days. Oral penetration is 2 days. That is a very, very small window, as well as digital penetration, which is 48 hours, 2 days. And when I say digital, I mean a finger has been inserted. Same as, penile swabs, 3 days. Skin swabs is 48 hours, but there is an exception to that, so up to 7 days if the patient's not washed. But obviously, if you've got a younger child and they've not washed for 7 days, that does add another safeguarding concern. And things like toxicology, so if it's a drug-facilitated assault, if there's been excessive alcohol involved, we can take, toxicology blood samples and urine samples to give to the police to test for those potential drugs or agents that have been used in the assault. Excuse me. So in terms of how you access the SARC, if you're working with a child or young person and they've made this disclosure of sexual abuse, excuse me, or sexual assault. So obviously, given we are a paediatric service, referrals always need to come from police or social care. However, that's not to say if you've just been sat with a young person or a child and they've disclosed what they've disclosed, that's not to say you can't ring us for advice. We are more than happy to offer that advice. But obviously with that, kind of your immediate actions would be to notify police and social care. Obviously there is an exception to that. If they're 13+ and it's acute, they can self-refer. But if you're a bit unsure, like I say, you can always ring us to ask. We're more than happy. There is always somebody available to speak to. We do have specific clinic hours, but Mountain Healthcare have a national call centre, which is open 24/7. So there's always a healthcare professional, you know, a doctor or a nurse to speak to and give that advice. If it's during clinic hours, you know, you would make a call through to our national call centre, which is our pathway and support service. You know, they record all the initial information and then they would transfer that to our local SARC, well, in this case, North Yorkshire, and that would go to our safeguarding and strategy manager. The job of the strategy and safeguarding manager is to liaise closely with social care and police. She participates in all of the strategy meetings, which I'll go into a bit more detail later on. You know, she is a non-clinical member of staff, but she ensures that she liaises appropriately with a clinical member of staff, so that could be a doctor or a nurse, and make sure that a correct advice is given. And then once all that's happened, we will then coordinate a SARC appointment. In terms of when you are referring, it's really important that we kind of know these key bits of information. So the details of the allegation, you know, what have they disclosed, what's your concern, your professional concern. I always say, I mean, forgive me, but what went where and when, because that basically enables us to establish, you know, how quickly we need to see them. Do we need to take forensics? That's kind of the key statement as to how quickly we would see a patient and whether it would be acute or non-recent. The timeline, so what's led up to them disclosing to you, you know, if you had concerns previously, it's all about that bigger picture, you know, that holistic approach to a child or young person when they disclose sexual assault or abuse. Do they have any known injuries or symptoms? One of the things that I would say about the SARC service is that we're not based in a hospital, and we don't have access to, you know, immediate medical care. So if you are dealing with somebody who's got significant injuries or they need that medical attention, medical needs come before forensic needs. So it's very important that they seek that medical advice from a hospital or the GP prior. Any safeguarding risks that we need to be aware of, you know, who holds parental responsibility for the child or young person, because it's always best practice to get consent from them, and who will be attending in terms of what professional, so social worker or police officer. We always ask a police officer to be in attendance if forensic swabs are being taken. That's solely because, you know, just for integrity wise, forensic integrity wise, chain of evidence, they have to be handed to the police straight away. So we always ask for them to be present when we're taking those swabs. So inside of the SARC, what would happen? You know, all the professionals have had the conversations. You know, we deem a SARC medical the appropriate course of action. The child would, as I say, would be accompanied by a parent or carer, as well as a professional. So that can be a police officer and or a social worker. The child or young person would be initially greeted by the crisis support worker. The crisis support worker is there to mainly chaperone the doctor. Obviously, we're doing quite an intimate examination, so it's to chaperone the doctor, but most importantly, they're there to advocate for the patient throughout. You know, one of the main messages that we give to our patients is that when they've been sexually abused or assaulted, they've had that control taken away from them. So when I've been crisis worker myself, the main message that I give them is that you're in complete control throughout all of this. You know, if you don't want a certain aspect of the examination, that is absolutely fine. If you want us to stop, we stop. So yeah, the crisis worker will meet them at the door and from the get-go build that rapport with them. They will be wearing their own clothes, and they'll kind of welcome them in, make them feel comfortable, ask any questions that they may have. You know, because sometimes we've had some parents and patients attend and you'll say, do you know why you're here? You know, how's the SARC being explained to you? And they'll say, oh, I'm here for an STI check, I'm here for a sexual health check, which is obviously very different. So we kind of address all that and obviously outline the SARC process in a bit more detail and be happy that they're happy to proceed. Once that's kind of happened, the doctor will come through. The biggest part of a SARC medical is is asking the questions, and that's not in relation to the assault. We never sit a patient down and say what's happened, because we don't, again, we don't want to re-traumatize them. It's about medical history, because that's all very important when a child has disclosed sexual abuse or assault, especially in the cases where there's been no disclosure. It's looking at the bigger picture. It's looking at all the factors that could contribute as to whether a child's been sexually abused or not. So yeah, the doctor would sit and ask a lot of questions with the professional. They would then speak to the parent or carer and get that medical background and consent. We then move to one of our examination rooms. Obviously, it's very clinical because we have to maintain that forensic integrity if it's a forensic case. And then both the doctor and crisis worker will change into clinical scrubs. If we are to take forensic samples, we will be wearing quite extensive PPE. Again, that's just to maintain the forensic integrity of the samples and to reduce the risk of any cross-contamination. But we always notify the patient or young person prior to us doing that, because we look significantly different. And then as part of the examination, it is a head to toe check initially. So we look over the skin, look for any bruises, any scratches that they may have, and then we would document that. And then following that, it would be, I call just what you'd expect from a routine doctor's appointment in terms of, listening to the chest for the heart, pulse, blood pressure, looking in the ears and the mouth, things like that. And then once that's been done, we would then move on to the genital and anal examination. The genital examination, obviously, like I say, we always reiterate that they are in control. So if they want us to stop at any point, we will do. We also do an examination of the anal area. But again, if they want to do that, that is completely their choice. Following that, we would take any STI swabs that need to be taken, and also take a test for BBV, which is a finger prick test, and that tests for things like HIV, hepatitis B and C, and syphilis. But again, as I've said, that's completely with their consent and if they're willing to do so. Once they've been in the examination room, we'll then move to a more comfortable room where we'll have what we call an aftercare session, which is when professionals will sit with the patient and the attending professionals and the parent or carer and outline any referrals that need to be made, complete any appropriate risk assessments, things like the CSE, mental health. Do we need to get immediate mental health intervention? That'll all be assessed then. The doctor will then complete the paperwork and hand over any exhibits if they've been taken to the police officer, and then the patient will be free to go. We do say that the average appointment takes around 2 to 4 hours, which obviously sounds a very significant amount of time. They're not in the examination for all that time. Like I say, the biggest chunk of what we do is getting that medical history and answering those questions that they may have. The examination itself usually takes around 20 to 30 minutes, sometimes longer, pending how significant the injuries are. But that can differ. We only see one patient at one time. All our focus is on one patient. We never have, it's not like the dynamics of a hospital where there's, several people around. We only see one patient at one time. So all our focus is on them. So if it needs to take more than 4 hours, then it'll take more than 4 hours. Just to touch a little bit more about the examination, there's a lot of myths that go around about SARC medicals and terminology, things like traumatic, it's intrusive. And obviously we completely acknowledge it's not a pleasant experience for a child or young person to go through, but just to give some reassurance. So if a child is a female, if they're prepubertal, so they've not yet started puberty, it will be solely an external examination. Nothing is inserted into a child. It's just something that we categorically do not do. On the other hand, if they're post-pubertal, so if they've started the periods, there is the option for the use of a speculum and catheter, a bit like when you're having your smear test, but that is only if the patient consents. If we start that and then they say no, it's too uncomfortable, we stop, we don't continue. Likewise with males, nothing is ever inserted into a penis. It's solely an external examination, at all times. It's swabs of the external area, nothing is inserted. The anal examination, we can use a proctoscope, which is similar to a speculum, however it goes up the anal area, and we only usually offer that in children or young people, sorry, who are older, but it's very rare that somebody does consent to this, but there is the option if they want to do so. So following the examination, and as I've touched on already about the STI screening aspect of what we do, we assess the risk of HIV infection. So that can be, it's assessed whether, what ethnicity is the patient, what kind of incident has it been, if they've got any injuries, and if that patient is deemed high risk to be exposed to HIV, we would then start the course of HIV PEP medication. In terms of the PowerPoint, it does say we start a regime. However, that's now changed. At SARC, we now have the ability to give the full course of HIV PEP whilst they're here. As I've mentioned, we do baseline STI screening, and that is routinely offered to all of our patients. And pending the time frame, we can facilitate follow-up if needed. I must add as well, that's only for 0 to 12 years old acutes. Anybody over the age of 13 will be referred to sexual health, and that's just the commissioning pathways that have been agreed. And then furthermore, we do assess the risk for exposure to hepatitis B. So if we deem that to be high risk, we will liaise closely with the patient's GP surgery or the sexual health, and ask for them to administer that injection as soon as possible. Safeguarding, like I said, at the start, it's a big part of what we do, given, we are a paediatric service and these patients have gone through what they've gone through. So we usually ask, and it is part of our pathways, that, children's social care are always notified before they attend SARC, and we always try and recommend a strategy meeting, ideally before a patient attends at SARC. That's, again, just so we can get the full picture of a child, any wider safeguarding concerns that we need to be aware of, in cases of familial abuse, is this child safe, who they're going to go home with, etc. So it's just a really key meeting to have prior to them attending SARC. There is exceptions to this, so if it's an acute forensic case, and if they've got injuries, we will see them without that strap meeting happening, because we won't allow a child or young person to go out of that forensic window or run the risk of an injury healing whilst we wait for the strategy meeting to occur. But we usually hold it afterwards, and that's when our strategy and safeguarding manager would come in, and she liaises closely with social care to make sure that meeting does happen at some point. Just to reiterate about, the importance of strategy meetings, I'm sure you're all aware, but, the purpose of a strategy meeting is to determine welfare and plan rapid action, if there's reasonable cause to suspect a child or young person is suffering or is likely to suffer significant harm. And obviously, given what we do and what a child or young person may have disclosed, they are deemed to be suffering or suffered from significant harm. So it's really important that we have those strategy meetings, ideally prior to them attending. But, it enables everybody to come together, to share that information effectively. We can enforce robust safety plans, like I say, in cases of familial abuse. Are they safe to go home? Is there other siblings to be considered? Have they been at risk? Have they made any disclosure of sexual abuse? It's that professional curiosity that we can embed, and strategy meetings give that, a really good platform to that. And it also allows for us to be invited, for us to advise of the correct pathway. Do we need to see them quickly? Do things need to happen before they come in, etc., etc.? And as I like to say, as part of my job, safeguarding is everybody's business. So the strategy manager, who I've spoken about prior, like I say, she attends all of the strategy meetings. And the main reason why this role came about is because we identified, as part of a theme in some of our clinical incidents, that we found that when these meetings weren't happening, children were referred without the appropriate information, especially if they were symptomatic and they'd had that problem before. They weren't referred in a timely manner, so injuries may have healed, or we've now surpassed that forensic time frame. There was more challenges following up children, young people who were not brought to the SARC, and in being involved in these strategy meetings, it allows us to really kind of stress and challenge the misconceptions around the appropriateness of the SARC. Many professionals do think it's not in the best interest of a child to have a SARC examination, but we really reiterate, like I've said, the key messages: they're in complete control, we're completely patient-led, we're child-led. If they don't want a certain aspect, it does not happen. They will not be pressured to do anything that they don't want to do. Opportunities to remind professionals about follow-up requirements, for STIs and pregnancy testing, for example. And also, as I've mentioned, that opportunity to consider other children and siblings. It's just really pivotal for us to have those details of those professionals involved, because it allows us, if we need to follow up, if we've got any immediate concerns, we have the contacts of the professionals needed to hand. And then, following on, so following SARC attendance, what do we do as a service to ensure our children, young people are safeguarded? So all of our patients are routinely referred to children's social care. These referrals will be completed on the same day of the patient's attendance. This can be either through an alert if we've had those strategy meetings beforehand, or if not, it'll be through a full MAR form, so a multi-agency referral form, to notify that the child has been and what has happened, etc. Our team, if it is a MAR form, our team then follow up that MAR form with the local authority within 72 hours, ensure the referral's been actioned, ensure we've got the appropriate details of the worker involved, and it allows us to liaise with them moving forward. We also offer welfare follow-up calls 2 weeks past SARC attendance. We get consent for that when they initially attend, and that's just for us to reach out to them, because we do appreciate, when they come to the SARC, we throw a lot of information at them and it can be very overwhelming. They've just gone through this trauma in terms of the incident, and you're trying to explain a lot of the services, the processes of what's going to happen. So we reach out to them, check in with them, check that referrals that we've made, other agencies have been in contact. If not, we can follow it up. And then also for our in-house STI nurse, going out into the community, going to the home addresses, it allows us to kind of assess the situation and then bring up to social workers if there's any concerns within the family home. Consent. So for consent for a SARC examination, best practice is that we always get consent from someone who holds parental responsibility for the patient. Ideally, this should be face-to-face, by the parent or carer attending the SARC with the child or young person. However, we do acknowledge that, cases can differ. There's exceptional circumstances. In cases of familial abuse, for example, it's not always appropriate to get consent from a parent or carer. If that is the case, every child, there's no kind of cut-off point, but every child is considered Gillick competent until they prove you otherwise. So our doctor can assess for Gillick competency. If they deem the patient to be Gillick competent, we can then proceed with the examination. If the patient is not deemed Gillick competent by the doctor and there's no parental consent in place for whatever reason, we unfortunately cannot do any examination on that child or young person. It would be for then us, the strategy and safeguarding manager, myself, to liaise urgently with children's social care to make sure that appropriate court orders are in place, things like an interim care order that gives social care the ability to be able to override parental consent to ensure that this patient gets seen. But obviously that can take time, but we try and act upon it as swiftly as possible. But there is times when that does happen, unfortunately, where parents don't consent for their own reasons. And as I've touched on already, our appointments are completely led by the patient. We really up on looking not just for those verbal cues, but those non-verbal cues. Do they look uncomfortable? Are they showing certain body language where, you just don't feel that they're happy to continue? So we'll always make sure that we respect their wishes. So if they want to stop, we stop, and that they're in complete control at all times. Obviously, I've touched on about how we're patient-led and child-led, and I think we can say it as much as we like, but I think it's always good to kind of give a bit of an overview. So these pictures in particular from the Hazelhurst Centre in Leeds, where I am at the minute, and we try our best to try and make it, as I don't like to fun, essentially. Some of the young patients that we see, unfortunately don't acknowledge what's happened to them is wrong. And with that, they can be very happy, very smiley, very engaging in the process. And we get a lot of positive feedback about the facilities that we have on site and how, child friendly it is, the resources, and like the sensory tent, as you can see, for young children, young people who've got additional needs and they just need somewhere to kind of hide out, relax a little bit. But we do get very positive feedback about the facilities that we have on site. And as I say, just some examples of the feedback that we have, I always appreciate the positive feedback that we get from parents and professionals. It's always really nice to see. I mean, some of the young people that we have, they've said to us that they don't want to go home. They just, I think one little girl said they just had a really good day at the doctor's. But even for your older people, they can come very reserved, rabbit in headlights, as we like to say. But to see the transition in it is essentially a short period of time, 2 to 4 hours, and they leave our service with a completely different person. They're laughing, they're smiling. It's just really reassuring to know that we do make that difference. So I've just kind of put on the screen the main differences between the two services. So the young people and adult service, obviously that's acute only. They're seen by a nurse, a crisis worker. It's acute cases only, and they're seen within forensic timeframes. We can offer injury checks if the patient's symptomatic, and obviously they're referred to sexual health for STI screening, which is currently based in York, etc. Likewise with the paediatric service, it's a doctor-led service. We're not 24/7. We offer both acute and non-recent services as well. And that's everything from me. An opportunity to kind of ask any questions that you may have. I do appreciate I might have just waffled on for a long period of time, so please feel free to ask any questions. And I'll leave that up on the screen. It's just some really key contact details if you were ever to need us. There's my email address on there, and our strategy manager as well, Anjali, who you can always email for any advice that you may need. But yeah, if anyone's got any questions, I'm more than happy to answer them.
Thanks very much for that presentation. It's been really interesting, very informative. It doesn't appear that anybody's got any questions, but obviously everyone's got your contact details there. Yeah. If they need to get in contact with you. Thank you very much for that. Really appreciate you coming and talking to us about that today.
You're welcome.
Just to finish off for today, just wanted to raise your awareness of some upcoming masterclasses that we have. Next month, our masterclass will be put back a couple of weeks due to the Easter holidays, but we've got one with the results of the Growing Up in North Yorkshire survey. So you'll be able to hear from Claire Barrowman there in relation to that. On the 2nd of May, a couple of weeks later, we've got the counterterrorism local profile. This is an updated version of the counterterrorism profile that we had in January. And then on the 5th of May, for any providers and childminders out there, we have the early years masterclass. That is an evening masterclass for you, a couple of hours. So it's probably best if you want to, if you're a childminder or a provider, then please book yourselves on that as well, because that will have relevant information for you. If you want any more information about any of our training courses, they're all available on our website, safeguardedchildren.co.uk. Just go to the professionals tab and then scroll down to the bottom of the menu that appears and select training, and all of that information is on there. What we ask is, on completion of a masterclass or any other training, can you please feedback via the NYES link that will be sent to you after the session. Also, this session, along with our previous masterclasses, or the majority of them, are accessible via our YouTube channel. The link is on the screen there. At the want of sounding like a typical YouTuber, would you please like and subscribe, particularly to our channel, so that if you want to visit any more of those, it's just so that we can get the number up to a specific level, so that we can actually name the channel, rather than having that really awful UCU and everything else name that we've got in that web address. You can also access all of those YouTube videos from links from our Learning for Professionals page, which again is on our website, safeguardedchildren.co.uk, and then go to professionals and then Learning for Professionals. Finally, these are just our normal contact details, our website. Don't forget, we're also on Twitter. We publish a lot of information available through Twitter, especially if there's any change of policies, practice, procedures, that sort of thing. We have our Facebook group, which is open to anybody. That includes members of the public. We have our YouTube channel, which I've obviously just mentioned, our Instagram, and also our podcast as well. There's several podcasts on there, various different topics, and you can obtain that from most service providers. We're not on iTunes yet, but we're looking to get on there. And of course, don't forget as well, you can sign up for our e-bulletin, which is the links on the screen, but you can also just go to our website, safeguardedchildren.co.uk, go to professionals, and then just go to NYSCP e-bulletin, and there's a sign up link from that page as well. That e-bulletin comes out on the first working day of every month, so if you're already subscribed, we'll be sending out the link for that later on today, the e-bulletin later on today. So again, thank you everybody for attending, and thanks to Mountain Healthcare for coming and talking to us today, and we hope to see you again next month.
Thank you very much. I apologise about the technical issues I had, but thank you all.
Don't worry, thank you.
Thank you.